Good evening, everyone, and thank you for logging in. My name is Dr. Sona Warrior from the medical team of USV, and I welcome everyone to yet another insightful session of Dr. KK's Med Talks. In today's session, we are going to be talking about an interesting yet concerning topic, prediabetes in children and adolescents, and how to manage the same. Prediabetes in our youth has been rising at an alarming rate over the last several years, and healthcare professionals play an essential role in tackling this increase. A good place to start is by building awareness. So, let's learn today about the factors leading to prediabetes in children and also how metformin, the wonder drug, now approved in India for use in prediabetes, is beneficial in this population. To enlighten us more on this subject, let me welcome Dr. Surya Kumar Singh, a renowned endocrinologist from Varanasi, who is a professor at Department of Endocrinology and Metabolism and also director at Institute of Medical Sciences at Banaras Hindu University, Varanasi. Thank you for being with us, sir. So we will jump right into our questions. In your clinical experience, what is the prevalence of prediabetes in children or adolescents that you have seen in day-to-day basis?
Thank you, Dr. Sona, for giving me this opportunity to interact online. And I take your first question. In my experience, what we see is around 5 to maybe 8% of children have obesity, and if we go for pre-diabetes, even 50% of that would be pre-diabetic. Though they may have the markers of insulin resistance in form of that their body weight more than 120%, they might have acanthosis nigricans. Many of them may have central obesity or abdominal obesity. But the pre-diabetes, as defined by the glucose intolerance, both in fasting and post-glucose challenge, is around half of that. So maybe 3 to 5% of our children are having pre-diabetes, which is much less than the prevalence of pre-diabetes in Western world. They might have it up to 15%. So against that, we are having. But I do not know if this prevalence is even higher in metro city. We cater to urban as well as to rural population. Therefore, we do not have that high prevalence of pre-diabetes in adolescents. But I expect that this might rise as we have of our children having obesity.
Thank you, sir. Thank you for making us aware about this, the number of pre-diabetes in children, and also you have mentioned very clearly about all the clinical markers, acanthosis nigricans, obesity, then all underlying conditions of insulin resistance. So, thank you for making us aware about that. Now, coming to the next question, what are the risk factors that lead to this pre-diabetes in children?
Yeah, but the risk factors that if they have obesity, which is primarily due to less physical activity and more abnormal food habits and keep on eating without any check, and sedentary activity, they do not play outside, they watch TV for longer hours, and they keep on eating because they get cue through advertisement which is shown on TV that you eat chips, you use pizza, you use so many things, and that actually very easily impress the unmatured mind of children. So they go on eating and they do not do physical activity. They have a risk of obesity, which is associated with insulin resistance, and then it progresses further, and they have the consequences of insulin resistance. Less physical activity, less glucose consumption by the body, that is another problem. So they have more of glucose level going up, and they have pre-diabetes. In addition, they have genetic predisposition, particularly those who have their parents diabetic. So if the parents are diabetic, they have some genetic predisposition of developing obesity and pre-diabetes. If they have associated problems and they receive some drugs which are known to antagonize effect of insulin, they have a risk of developing pre-diabetes, particularly those who are on various types of steroid for either respiratory problem or for renal or lung lesions. They also have a risk of developing diabetes, pre-diabetes. So, in brief, I think this is most important that they do not put on weight and they are involved in more physical activity. Okay.
Yes, sir. Yes, sir. So, dear audience, so this is the baseline of the prevalence of prediabetes, talking about the lifestyle that now children and adolescents are living, their food habits, their sedentary lifestyles, and along with, as sir was mentioning, genetic predisposition like family history. So, all these are the risk factors leading to prediabetes. Sir, now I would like to know what are the glycemic parameters in prediabetes in children, and how often do we screen them?
Yep. The first glycemic parameters for making diagnosis of pre-diabetes in children is almost the same as it is in an adult. That if the fasting blood plasma glucose more than 100 to 125 in the fasting state, which is about 8 to 10 hours, and post glucose post glucose value of between 140 to 200 milligram per deciliter. This is in the 2 hours value after glucose challenge, which is around 1.75 gram per kg body weight to maximum of 75 gram. So if that challenge is given 2 hours later, the sugar level more than 200, between 140 to 200, this is pre-diabetes. The this test should be done in all those who have their BMI more than 85th percentile, or the body weight is more than 120% for that particular age in children. It is important to look at the age, and the BMI we always take it in form of the percentile. The body weight more than 120%. So these are the children or adolescents who have a risk of developing pre-diabetes, or on clinical examination, if they have acanthosis nigricans, there is a chance of having pre-diabetes and they should be screened. Otherwise, mass screening for pre-diabetes in children is not required. They do not have a risk of developing pre-diabetes unless they have these abnormalities associated, and then they should be screened for pre-diabetes by the glucose challenge and the cutoffs that I have explained.
Right, sir. Thank you for making enlightening us about these very important. It is very important to screen for prediabetes in children when they are showing these risk factors of obesity, BMI, high percentile of BMI, and age also is a factor in screening for prediabetes in children. Sir, now it is said that therapeutic lifestyle intervention remains the first step in managing prediabetes. So, in children, what are the common lifestyle measures advised?
Yeah, the first thing that they should be encouraged to do physical activity, which is possible with the games, play outdoor. So they, if they are encouraged to play outdoor, the school should also focus, because most active time is spent in school, and they should have the physical activity class, so that they have a chance of having more physical activity outside. In home also, they should be encouraged and they should be involved in various activities, particularly the physical activity. Means even children may participate in some of the household work, particularly the maintaining lawns or the garden. They can play. and they can also assist their parents in gardening. So these are the good things to do for children. In addition to that, we have to be very careful that their diet is very ideal. They should not eat too much of carbohydrate. They should not take sugary diets, particularly soft drinks, because sugary diets are very indulgent, very palatable for children, and even the carbohydrate, the fried food, that actually promotes their appetite, and they eat too much of calorie while they do not do physical activity. So that is the second important thing that we must focus on, their calorie intake, and we should encourage them to take roughest food with roughest, particularly homemade foods, that will help, because you know what you are preparing it with, and that will help. Uh, we usually blame the fast food, which I also believe that that might be the cause, but for simple reason that we really do not know what does it contain. The fast food contains too much of refined carbohydrate and fat, which is not good for the children. So lifestyle modification is very important, I would say. We have conducted a study in our place, and we found that most of the children are actually having a problem of eating, and their parents, they offer, in fact mother has more uh, has in fact the mother has interest in feeding the child, thinking that child will be very strong and will be free of disease. And even if, when we counsel them that they should not go for too much of calorie, they should not offer to their children, they resist. They say, no, I'm not offering anything extra. Most of the children are also eating the same, so how can this be responsible for overweight? So this is also very important that parents should understand. They do not measure the calorie taken up by their children, and they get excess calories. So education of the parents is equally important. It's not that we educate the child and we educate, ask them to go for more physical activity, but parents should also be taught what to offer to their children so that they do not put on weight. That's very important. Even adolescents, they should be uh, educated that what kind of food would be all right if they go outside, outdoor, go for eat outs. What calories should they consume so that their body weight is not increased?
Right, so thank you. It is very important to understand what lifestyle measures should be applied to children. Physical activity should be encouraged right from school, and outdoor activity should be encouraged. Diet also plays a very, very major role. Homemade food, as I was mentioning about the roughage, the fibers, and the most important is education and awareness of the parents, because they are the ones who are nourishing the lives of their children. So if that is taken care of, then lifestyle modifications like outdoor activities, lack of sedentary, and diet also can be taken care of. So thank you, sir. Now coming to the pharmacological management of pre-diabetes in children. So sometimes it is very important to understand where it is necessary to intervene with the pharmacological treatment. Sometimes lifestyle modifications just does not help in reducing the glycemic control, like glycemic parameters. So in your opinion, when can this pharmacological treatment be introduced in children, management of prediabetes in children?
Yeah, that's very important question in relation with obesity in children, the pharmacological therapy. As I initially emphasized that the lifestyle modification is most important. We have very limited uh, scope of using agents or medical treatment for children with obesity or with pre-diabetes. In fact, the pharmacotherapy is available for pre-diabetes only, not for obesity in children. And the metformin is one drug by Genites. This is the one drug which is approved by FDA also, and DCGI has also approved for treatment of pre-diabetes. In children, it is approved only after age of 10 years, not before age of 10 years. So it is approved after age of 10 years and only for pre-diabetes. So one should first focus on lifestyle, give a chance of lifestyle modification. If that doesn't work, or the weight loss is not achieved by the lifestyle, there is a scope of adding metformin, medical therapy, but with the intent not to reduce weight by metformin. The metformin is used to improve pre-diabetic status, not for weight reduction, though the addition of metformin might help in weight reduction. Weight reduction could be there to an extent. Some of the studies have shown that there had been weight reduction with metformin. And in my clinical experience, I have found many of people, patients, saying that metformin has led to significant weight loss. But again, as I said, that in general, this is not a drug for weight loss. It might cause weight loss, some of the individuals. I really do not know the reason. I really do not know any information available in literature why some of them do lose weight with metformin and many of them actually do not lose weight at all with metformin. Theoretically also metformin may not affect the weight, except that because of some GI upset or maybe because of the some loss of weight, some gastritis associated, or loss of taste. Many times this medicine causes a change in the taste that might lead to weight loss, but as such it is not a weight reducing drug. So one should never use it in children for weight reduction, always should use for pre-diabetes, which is going to be converted into frying diabetes in time to come. So these are the people, these are the children who are suitable candidates for metformin. A, if they have established pre-diabetes associated with obesity. B, if they have high risk of developing diabetes with time. And this is very important. If they have family history, their other siblings are having the same problem, they are sharing the genetic factor, so they are the good candidate for pharmacotherapy. And those who are not complying to diet or not responding to diet modification and lifestyle modification, they are the candidate for metformin therapy, because then there is no choice. Metformin helps, and helps in prevention of development of type 2 diabetes in children and adolescents.
Thank you, sir. So
Right?
very clearly segregating this population for the need for intervention of metformin. So there are some very high risk pre-diabetes children who are at a high risk of developing diabetes, also considering their family history, considering their obesity or any underlying pathophysiology. So in such population, it is very important to start with metformin as a pharmacological agent, because it is safe, beneficial, and also now approved also in pre-diabetes. So thank you, sir, for that. And so you were mentioning about a lot of trials. So there is one such trial called as metformin in obese children and adolescent trial in the UK, and which has been the largest trial of metformin in children and pre-diabetes, children with pre-diabetes. So could you tell some of the details or the results of this trial to our esteemed audience?
Yeah, right. Yeah. This is a MOCA, MOCA trial, metformin and obesity in children with children and adolescents. They have included not very large number of obese and pre-diabetic children, 151, if I remember correctly. Long ago, almost a decade ago, this trial was conducted in UK, and but the data was quite reassuring that they were benefited by this over a period of 6 months. There had been improvement, significant improvement in those who received metformin as for their glycemic parameter were concerned, there was significant improvement. The other group received only lifestyle modification, not the medicine. So, in comparison with that, there had been significant improvement in the pre-diabetic status. Weight loss was also noted in this study. Some of the children had weight loss, but overall, the weight loss in 6 month time there was a weight loss, but it was not very significant in all the children overall. There had been weight loss in the metformin group without metformin. Weight loss was slightly higher because the other group received only lifestyle modification. So the MOCA trial data is definitely very convincing, and some more meta-analysis of the trials, though they have not selected the similar similar population. They have not selected the 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 treatment protocol had not been almost similar, but still the data was uh, there had been constancy in most of the trials with metformin on in children and adolescents. Uh, the meta-analysis actually done on 11 study, if I remember, 11 study with metformin, and some of the study had very small sample size, but over around 5,000 5,000 patients included, and there had been constancy in these trials with metformin.
That's quite reassuring, sir, knowing that there have been trials, global trials happening on metformin in children and pre-diabetes, and the results also are convincing enough. So, these trials that are happening on children in pre-diabetes, children with pre-diabetes, so the major mechanism or the major benefit is weight loss in some, and the effect of metformin in insulin resistance as well. So, considering all these facts, the results in these trials have been quite reassuring. Yes, thank you, sir. So, the one more question that I have is the safety profile of metformin. So, in children. So, what are your thoughts about that?
Yeah, the side safety is quite safe, except that our GI problems, most of them, had some bad test or some evidence of gastritis. Some of them had diarrhea or loose motion, and some of them complained of griping pain, abdomen. But overall, this is not very prevalent amongst those who were on metformin, and reducing dose had helped in some, or sometimes stop the treatment and restart with a smaller dose, and these side effects can be overcome. So there had not been any serious side effects with metformin uh, in this study, particularly the MOCA study. There had not been very serious problem with metformin, as we also see in adults, and other than that GI upset. And many times we have to reduce the dose of metformin, particularly for those who have diarrhea, and it works. Uh, the vitamin deficiency is another issue with metformin, and supplement of vitamin B12, adequate amount of milk intake for calcium, that will help in preventing vitamin deficiency and anemia occurring with metformin.
Yes, sir. Thank you for clarifying that as well. So now that we have reached the end of our chat show, I would like to know a summary and concluding thoughts about the use of metformin in pre-diabetes in children. So, any concluding thoughts, anything that we have missed, you can all cover up. Of course, we know that only this much time is not enough to talk about metformin, but your thoughts on the same.
Yeah, the only thing we didn't discuss the dose of metformin in adolescent
Yes,
children
sir.
and adolescents.
Yes, sir, please. Yes.
That is also very important. So you know that around this should be given in dose of 20 milligram per kg body weight, 20 to 25 milligram per kg body weight. But we all understand that obese children also almost have 120% of their ideal body weight, which will be around 40 to 50 kg in 10 years and 12 years obese children. So that should be the dose. And the important, as we already discussed, the indication of metformin therapy and the duration of metformin therapy, that is also important. If the lifestyle modification is adhered to and there is a 10% of body weight loss, that will correct the metabolic abnormality, or that will improve significant insulin resistance. The metformin can be a kind of bridging the therapy. You just start metformin and lifestyle in the beginning, and once the body weight is achieved and the glycemic parameters are restored to normal, uh, only lifestyle modification or lifestyle change should be continued. That should be the ideal situation. We should not uh, depend on pharmacotherapy in these population, because very long term effect of metformin really we do not know. uh, I suspect that many of these long term use may not improve the insulin resistance in the muscle. It might improve some insulin resistance in the hepatocytes, but insulin resistance in the muscle may not be improved in long term. And therefore, again, I emphasize that lifestyle, physical activity is very, very important. So, do not, the patient should be, or their parents should be taught or given this information that we are prescribing metformin as we are cornered, we are compelled to prescribe it in your children. If you stick to lifestyle modification, perhaps the child will not require metformin for a very long time. So that should be the education while we are prescribing metformin in children.
Right, sir. Thank you. Thank you so much for your clinical pearls. As we were mentioning, awareness is very important in children in today's world, where children and adolescents are also prone to pre-diabetes and at the risk of developing diabetes because of lifestyle changes or genetic disposition. Lifestyle modifications will always remain the mainstay of management in pre-diabetes. However, when lifestyle modifications will not work, and if if children and the adolescent is at high risk, is falling into the high risk category of pre-diabetes, such as high BMI, family history, other insulin resistance comorbidities such as PCOS. So, in such patients or in such children and adolescents, it is sometimes imperative to start with a small dose of pharmacological agent to control the progression to diabetes, and without compromising on the lifestyle modifications, because as we mentioned, it remains the mainstay. So thank you, sir, for covering all the aspects of prediabetes in children, right from the risk factors, the
Thank you.
screening, the types of lifestyle modifications, and the all the aspects of metformin use in prediabetes as well. So thank you so much, dear audience, also for logging in. Have a good day, and I hope these clinical pearls are useful in the management of prediabetes in children and adolescents that we see rising in today's world. So thank you so much. Thank you, sir, and have a great evening
Thank
ahead.
you. Thank you.
Thank you.
Thank you. Good evening.